Welcome to the deep dive. Today, we're not just scratching the surface of a medical concept. We're plunging into a topic that is, well, as fundamental as life itself, yet remains profoundly complex. We're talking about shock. Not the feeling, but the medical state, a terrifying, intricate physiological cascade. Samuel V. Gross, way back in 1872, described it so powerfully as the rude unhinging of the machinery of life. That phrase alone, it just gives you a sense of the gravity, the complexity we're about to explore. Our mission today is to really deeply unpack the complexities of shock. We'll journey from its earliest historical understandings, through the body's intricate, often surprising cellular responses, and right up to cutting-edge management strategies. This is a deep dive for anyone who genuinely wants to master this vital medical concept, to really understand it from the cellular energy crisis right up to the macro-level clinical picture. By the end, you'll gain a comprehensive, truly expert-level understanding of shock, its myriad forms, the body's intricate, sometimes desperate responses, and the critical life-saving decisions made in its treatment. Get ready to connect some crucial dots here.
And that profound statement by Gross, it really does set the stage perfectly for our discussion. Understanding shock isn't just a theoretical exercise. It's absolutely crucial because it represents a critical state where the body, at its most fundamental level, fails to meet its metabolic needs. Think of it like the core machinery breaking down.
Right.
This isn't just about feeling unwell. It's about a cascade of consequences that, well, if unchecked, can lead to irreversible damage, widespread organ failure, and ultimately death. What's truly fascinating, I think, is how our comprehension of this state has matured so significantly, especially throughout the 20th century. We've moved beyond just basic observations to, deep physiological and pathological insights. We're continually refining our understanding of how the body responds to such extreme stress, really striving for that master-level grasp.
Okay, let's unpack this then. We hear the term shock often, but at its most fundamental level, what is shock in a medical context?
Right. At its core, shock is precisely what you described.
Yeah.
It's the failure to meet the metabolic needs of the cell, regardless of what caused it. Imagine every single cell in your body is a tiny, highly specialized factory. Each one needs a constant, uninterrupted supply of energy, primarily oxygen and nutrients, just to function.
Okay.
When that supply gets disrupted and the demand isn't met, those cellular factories start to break down. Now, initially, this cellular injury is reversible. If you intervene quickly, effectively, those cells can recover, they can repair themselves, resume normal function. However, if this state of insufficient tissue perfusion, meaning, inadequate blood flow and oxygen delivery to the tissues, if that's prolonged or severe enough, the injury progresses. At that point, the cellular machinery, it just can't compensate anymore. The cells begin to die, and that leads to organ dysfunction.
And clinically, what are we seeing? What guides the diagnosis?
From a clinical perspective, what we often observe as practitioners are the body's powerful sympathetic and neuroendocrine stress responses acting on the cardiovascular system. These visible signs, like changes in heart rate, blood pressure, they're often what guide clinicians to diagnose and begin management. But here's a really crucial caveat, something that often catches even experienced clinicians. Hemodynamic parameters, things like blood pressure and heart rate, they're actually relatively insensitive measures of shock.
Relatively insensitive. Okay.
That's surprising. It is. A patient can be in significant shock, their cells struggling desperately, while still maintaining what looks like a near-normal blood pressure or heart rate. This is because of those early, vigorous compensatory mechanisms kind of masking the underlying danger.
The body's trying to hide it.
Exactly. And this underscores the critical need for additional considerations beyond just vital signs for early diagnosis and, maybe more importantly, early and aggressive treatment. So the general empiric approach, the first steps, always prioritize securing the airway, ensuring adequate ventilation, immediately controlling any obvious hemorrhage if the patient's bleeding, and then working rapidly to restore vascular volume and tissue perfusion. That's really the bedrock of professional shock management.
That's a crucial point, that vital signs can be deceptive. So given that challenge, what's the most common pitfall clinicians fall into when they rely solely on those traditional signs? And, to truly appreciate this modern understanding, we really need to go back in time, look at the historical background that laid the groundwork. Where did this journey of understanding begin?
Well, the biggest pitfall is probably complacency, assuming normal vitals mean normal physiology, because the body is just a master of compensation up to a point. As for our historical journey, the foundational concept for understanding shock, and really for much of modern medicine, truly began with Claude Bernard in the mid-19th century. He introduced this revolutionary idea that an organism actively tries to maintain constancy in its milieu intérieur, its internal environment against external disruptions.
The internal balance?
Precisely. This was the precursor to what we now call homeostasis. Then Walter B. Cannon, building on Bernard's observations, later coined the term homeostasis and powerfully emphasized its link to survival. He really got that an organism's ability to live depended on its capacity to maintain this internal balance. When physiological systems fail to buffer the organism against these external forces, that's when organ and cellular dysfunction sets in. That's what we clinically recognize as shock.
And Cannon also described the fight or flight response.
He did. He vividly described the fight or flight response, detailing how elevated levels of catecholamines, adrenaline, noradrenaline drive this immediate reaction. His observations extended to the battlefields of World War I, where he saw firsthand the devastating effects of severe injury. From this, he proposed that the initiation of shock was primarily due to a disturbance of the nervous system, leading to widespread vasodilation and dangerously low blood pressure. He also put forth a hypothesis for what he called secondary shock, suggesting it was caused by a toxic factor released from damaged tissues, which then led to capillary permeability leak throughout the body, a sort of poison from within.
A toxic factor. That sounds a bit vague now. Did that hold up?
Well, that's where the scientific journey took a turn. Alfred Blalock, through a series of really critical experiments in the 1930s, challenged Cannon's toxic factor hypothesis, specifically for hemorrhagic shock. Blalock meticulously documented that the shock state in hemorrhage was actually associated with a reduced cardiac output due to direct volume loss.
So it wasn't a toxin, it was just not enough volume.
Exactly. It was a volumetric problem, not a toxic one. This was a pivotal shift, moving from a somewhat vague concept to a concrete physiological explanation. Then, in 1934, Blalock went on to propose the first widely accepted categorization of shock, dividing it into four primary types: hypovolaemic, vasogenic, cardiogenic, and neurogenic.
Okay, so let's quickly define those original four Blalock's categories.
Sure. Hypovolemic shock, as Blalock noted, is the most common. It results from a loss of circulating blood volume. This could be whole blood loss, hemorrhagic shock, or plasma loss, like from severe burns, or even interstitial fluid loss, maybe with a bowel obstruction. The core issue is just not enough fluid in the pipes.
Got it.
Vasogenic shock he described as resulting from a widespread decrease in resistance within the capacitance vessels. Think of your blood vessels getting much wider, reducing the pressure inside. This is often seen in conditions like sepsis, where vessels lose their tone.
Okay, leaky pipes, essentially.
Sort of, or rather, overly relaxed pipes. Then neurogenic shock was considered a specific form of vasogenic shock. Here, spinal cord injury, or spinal anesthesia, causes that widespread vasodilation because of an acute loss of sympathetic vascular tone. The brain loses its control over vessel constriction.
The control system is down.
Precisely. And finally, cardiogenic shock was defined as a failure of the heart itself as a pump, like in severe arrhythmias or massive heart attack.
Yeah.
The pump itself is failing, regardless of the fluid volume.
It's incredible how much Blalock got right, even back then. But what about common misconceptions? Did any of his initial ideas prove completely off base, or was it more about refinements over time? And how have those initial categories evolved into the classifications we use today?
That's a great question because science is all about refinement. His toxic factor hypothesis, for instance, that was later meticulously disproven, actually by Blalock himself, through his experiment showing it was about volume loss.
Right, he corrected his own field's earlier idea.
Exactly. A perfect example of how understanding evolves with rigorous experiment replacing speculation. And you're absolutely right. Blalock's categorization persists, but it's been significantly refined and expanded. While the fundamental principles remain valid, our increased understanding of the underlying pathophysiology has led to a more nuanced classification. Today, we typically recognize 6 distinct types building on that framework: hypovolemic, septic, which is a type of vasodilatory shock, neurogenic, cardiogenic, obstructive, and traumatic shock.
Okay, so 2 new ones, obstructive and traumatic. Tell us about those.
Let's elaborate. Obstructive shock is a really critical distinction. While it shares features with cardiogenic shock, both result in depressed cardiac output. It's fundamentally different. It results from a mechanical impediment to circulation rather than a primary failure of the heart muscle.
Like a blockage.
Exactly. The heart pump might be working fine, but something is physically blocking the pipes, preventing blood from getting to it or leaving it effectively. This mechanical obstruction leads to that depressed output. Classic examples are a massive pulmonary embolism,
Wow.
a large clot blocking blood flow to the lungs, or a tension pneumothorax, where trapped air in the chest compresses the heart and great vessels, literally squishing the pump.
Okay, physical obstruction and traumatic shock.
Then there's traumatic shock. This one is particularly complex because it's rarely just one thing. It's a combined insult, an intricate interplay. You have soft tissue injury, bony injury, and blood loss, all activating a profound systemic inflammatory response. This involves inflammatory cells getting activated and releasing circulating factors, cytokines, various intracellular molecules which dramatically modulate the immune response.
Yeah.
And what recent investigations have revealed is truly critical here. The inflammatory mediators released in response to direct tissue injury, what we now call damage-associated molecular patterns, or DAMPs. These are recognized by many of the very same cellular receptors.
The PRRs.
Exactly, the pattern recognition receptors, PRRs. These are the same receptors that are activated by bacterial products in sepsis, the pathogen-associated molecular patterns, PAMPs, like lipopolysaccharide.
Wow. So the body uses the same alarm bells for a physical injury as for an infection.
That's the key insight. Your body uses the same fundamental alarm system. And the profound consequence is that this combination of direct tissue injury and hemorrhage creates a far more complex and significantly amplified deviation from homeostasis than either insult would alone. It's not just additive. It's like an exponential escalation.
Okay, that makes sense. It's a combined amplified assault.
Exactly. And understanding that distinction is vital for a master-level approach, as it really impacts treatment strategies. You have to address all components.
Here's where it gets really interesting then. Regardless of the specific cause, massive bleed, severe infection, trauma, what's happening universally inside the body when it's in shock, what's the core physiological meltdown?
You've hit the critical point. While the initial trigger might differ, the fundamental physiologic responses in shock are always driven by tissue hypoperfusion, that inadequate blood flow and oxygen delivery, and the resulting cellular energy deficit. This imbalance between what the cells need and what they receive sets off a chain reaction. This leads to powerful neuroendocrine and inflammatory responses. And crucially, the magnitude of these responses is usually proportional to the degree and duration of the shock.
So longer and deeper shock means a bigger, more frantic response.
Generally, yes. The longer and more severe the oxygen debt, the more intense the body's reaction. However, the specific manifestations will differ based on the cause. For instance, in neurogenic shock, where the nervous system's control is off, or in septic shock with its widespread vasodilation, the usual cardiovascular response driven by the sympathetic nervous system is markedly blunted.
It can't compensate properly.
Right, it can't compensate in the usual way, leading to very different clinical signs. And it's vital to understand that decreased perfusion isn't just a direct result of blood loss or heart failure. It can also come from cellular activation and dysfunction caused by microbial products and infection, or by those endogenous cellular products, the DAMPs, released from tissue injury, like we talked about in traumatic shock. Many of the body's organ-specific responses during shock are ultimately aimed at maintaining perfusion to two absolutely critical organs, the brain and the heart.
Prioritization.
Exactly. These vital areas have elaborate regulatory mechanisms trying to preserve their blood flow even when the rest of the body is struggling. This involves intricate interplay between stretch receptors, baroreceptors, chemoreceptors sensing O2 and CO2, cerebral ischemia responses, the release of powerful endogenous vasoconstrictors, even shifting fluid into the vessels and the kidneys, working overtime to conserve salt and water. Furthermore, these responses aren't static. They vary dramatically over time and in response to resuscitation. In hemorrhagic shock, for example, the body can initially compensate for blood loss, mainly through that robust neuroendocrine response increasing heart rate, constricting vessels to maintain hemodynamics. This is the compensated phase of shock. The patient might look relatively stable, but underneath, cellular injury is already starting.
That's the insidious part.
It really is. Because if hypoperfusion continues, and often it can go unrecognized by traditional vital signs, cellular death and injury are ongoing. This leads into the decompensation phase of shock. Here, microcirculatory dysfunction, widespread tissue damage in organs, and inflammatory cell activation all start to perpetuate the hypoperfusion. It becomes a vicious cycle.
Feeding itself.
Precisely. And adding insult to injury is something called ischemic perfusion injury.
Right, when blood flow returns but causes more damage.
Exactly. When blood flow is finally restored to tissues that have been starved of oxygen, it paradoxically causes even more damage due to a rush of oxygen radicals and inflammatory mediators.
Wow.
If these effects at the cellular level aren't treated, they compromise function at the organ system level, creating that vicious cycle of shock. Think of it. Decreased tissue perfusion, cellular hypoxia, metabolic acidosis, parenchymal cell injury, endothelial activation, microcirculatory damage, cellular aggregation, intracellular fluid loss. It just keeps feeding
The
forward.
word spiral.
A relentless cycle. If allowed to continue, it leads to further hemodynamic collapse. This grim stage is termed the irreversible phase of shock. It can develop quite insidiously and often only becomes obvious in retrospect. You only realize it after the fact.
Too late.
Often, yes.
Yeah.
At this point, there's such extensive tissue and microvascular injury that even aggressive volume resuscitation fails to reverse the process, inevitably leading to death. Experimental models like the modified Wiggers model helped us understand this. They'd slowly return shed blood to maintain hypotension and observe when the animal could no longer compensate the compensation endpoint. If it progresses further, even giving back all the blood won't save it. That's irreversible shock.
That's a powerful description of the body's desperate fight.
Yeah.
So the body has this master plan, you said, to protect itself, right? And prioritizes. What are the key systems involved in this, especially when we talk about hemorrhage?
Absolutely. The body does have an incredible, highly evolved master plan for survival. In the face of hemorrhage, the overarching goal of the neuroendocrine response is, as we said, maintaining perfusion to the heart and the brain. This prioritization happens even if it means severely compromising other organ systems.
Sacrificing the periphery for the core?
In essence, yes. The body achieves this through intense peripheral vasoconstriction, diverting blood centrally, and by inhibiting fluid excretion to retain every drop of volume. The mechanisms are complex. Autonomic control of vascular tone and cardiac contractility, a broad hormonal response to stress and volume depletion, and local microcirculatory mechanisms regulating regional blood flow very specifically. The initial stimulus is the loss of circulating blood volume, and the magnitude of this whole response depends on both how much blood is lost and, critically, how quickly it's lost. A rapid, large loss triggers a much more dramatic response.
Okay, so how does the body sense this danger, and then how does it act on it? The signals in and the actions out.
Great way to put it. Let's break down the afferent signals, sensing the danger, and the efferent signals acting on the body. First, the afferent signals, impulses transmitted from the periphery, processed in the CNS, activating the reflexive effector responses. Pain. Just the sensation of pain from injured tissue, sent via spinothalamic tracts, immediately kicks off the hypothalamic pituitary adrenal HPA axis and the autonomic nervous system. This leads to direct sympathetic stimulation of the adrenal medulla, unleashing catecholamines.
Adrenaline rush.
Exactly. Baroreceptors. These are absolutely crucial. We have volume receptors in the heart atria sensitive to even small pressure changes from low volume hemorrhage. Then receptors in the aortic arch and carotid bodies respond to larger volume or pressure drops. Normally, these baroreceptors inhibit the autonomic nervous system, but when activated by low volume, their output diminishes. This disinhibits the ANS, causing a surge in sympathetic output via the brainstem, leading to centrally mediated peripheral vessel constriction. It's like taking your foot off the brake.
Okay, the brake comes off, constriction happens.
Precisely. Chemoreceptors. Located in the aorta and carotid bodies, these sense O2 tension, H plus ion concentration, acidity, and CO2 levels. When stimulated by low oxygen or acidosis, they cause vasodilation of coronary arteries, slow the heart rate, but crucially, cause vasoconstriction of the splanchnic gut and skeletal circulation, further shunting blood centrally. Inflammatory mediators. Beyond neural and hormonal pathways, various mediators produced at the injury site, histamine, cytokines, eicosanoids, endotolins, also act as afferent impulses, adding to the overall host response.
So a whole range of sensors are feeding information back. Then what are the efferent signals, the body's actions?
Right, the efferent signals, the counterattack, cardiovascular response. This is prominent clinically. Hemorrhage, diminished venous return, decreased cardiac output. The body compensates. Increased heart rate, increased contractility, widespread venous and arterial vasoconstriction. Sympathetic stimulation of the heart via beta-1 receptors increases heart rate and contractility. But this increases myocardial oxygen consumption. If that demand isn't met, the heart itself can falter.
A potential downside to the compensation.
A critical one. Direct sympathetic stimulation of peripheral circulation via alpha-1 receptors causes vasoconstriction, increasing systemic vascular resistance to maintain blood pressure. But this vasoconstriction is not uniform. Blood flow is redistributed, shunted away from less essential beds like the intestine, kidneys, skin, to preserve flow to the brain and heart, which have their own autoregulation.
Selective shutdown.
Yes. Venous constriction also helps by decreasing the system's capacitance, speeding blood return. The adrenal medulla releases catecholamines, epinephrine mainly, norepinephrine from nerve synapses, peaking 24-48 hours after injury. Persistently high levels suggest ongoing problems. These catecholamines also have metabolic effects, triggering glucose release from the liver, muscle glycogen breakdown, suppressing insulin, increasing glucagon, all to mobilize energy.
Okay, cardiovascular response is huge. What about hormones?
Hormonal response is another crucial layer. Hypothalamic pituitary adrenal, HPA axis. Shock stimulates the hypothalamus releases CRH. Pituitary releases ACTH, adrenal cortex releases cortisol. Cortisol works with epinephrine and glucagon for that catabolic state, stimulating glucose production, causing insulin resistance, hyperglycemia, breaking down muscle protein and fat for fuel. Critically, cortisol also helps kidneys retain sodium and water. In severe hypovolemia, ACTH secretion can even bypass normal cortisol feedback. The body overrides its usual checks.
Pushing past the limits.
In an emergency, yes.
Yeah.
Renin-angiotensin system. This is powerfully activated. Decreased kidney perfusion, beta-adrenergic stimulation, increased renal sodium trigger renin release. Renin converts angiotensin from the liver to angiotensin I. Then ACE enzyme, mostly from the lung, converts that to angiotensin II. Angiotensin II is a very potent vasoconstrictor, especially in the gut and periphery. It also stimulates aldosterone, ACTH, and ADH release.
A real cascade effect.
Absolutely. Aldosterone. This mineralocorticoid acts on kidney nephrons for sodium reabsorption, and water follows, while causing potassium hydrogen loss. Key for long-term volume conservation. Vasopressin, ADH.
Yeah.
The pituitary releases ADH, or arginine vasopressin, AVP, due to hypovolemia. Signals from baroreceptor satial stretch receptors increase plasma osmolality. Epinephrine angiotensin II, pain, hyperglycemia also boost it. ADH levels can stay high for about a week. It acts on the kidney nephrons to increase water permeability, decreasing water sodium loss. It's also a potent mesenteric vasoconstrictor, shunting blood from the gut, which might contribute to intestinal ischemia in shock. It also increases liver glucose production.
So many overlapping systems trying to achieve the same goals.
Exactly. And interestingly, in sepsis, endotoxin and cytokines can directly stimulate ADH release, independent of the usual triggers. Also, patients on chronic ACE inhibitors are more prone to hypotension and vasodilatory shock, potentially due to low ADP levels.
That's an incredibly detailed explanation of how these systems prioritize and act. To tie all those hormonal actions together, you can see the body is essentially hitting every single button. It has adrenaline, cortisol, ADH, angiotensin, all aimed at conserving volume, shunting blood, mobilizing every last bit of energy for survival. It really highlights that this is a truly integrated system, with the heart and vessels working together, trying desperately to keep blood flowing to critical areas. Let's talk about that integrated dance, the mechanics of circulatory homeostasis.
Indeed, it's a symphony of finely tuned, interconnected systems. For a master-level understanding, we need to grasp how the heart and vessels interact. Preload. Think about this.
Yeah.
At rest, most of our blood volume, maybe 70%, is in the venous system. It's a flexible reservoir. The amount of blood returning to the heart-venous return directly generates the stretch on the ventricle walls just before contraction, the end diastolic wall tension. And this tension, or preload, is a major determinant of cardiac output.
How much the heart fills determines how much it pumps out.
Basically, yes. When you stand up, gravity shifts blood. But dynamic changes in venous capacity, active contraction of vein muscle, passive recoil quickly correct this, pushing blood back to the heart. Most changes in cardiac output in a healthy heart are actually related to these preload changes. Increased sympathetic tone, for instance, can dramatically reduce splanchnic blood volume. The gut reservoir, holding maybe 20% of total blood, significantly boosting venous return. While the kidneys handle long-term volume, saltwater balance, hormones, the acute responses to volume changes involve venous tone, systemic vascular resistance, SVR, and intrathoracic pressure changes.
So preload is critical. What about the contraction itself?
Ventricular contraction. The Frank-Starling curve describes this fundamental relationship. Essentially, the more the heart muscle fibers are stretched, preload, the greater the force of contraction, up to a point. But intrinsic heart disease, like a weakened muscle, shifts this curve, altering performance. We've seen experimentally that cardiac dysfunction can occur in various shock states: burns, hemorrhagic, traumatic, septic shock, further complicating the heart's ability to respond.
And the resistance the heart pumps against. Afterload.
Afterload, right. This is the force resisting myocardial work during contraction. Arterial pressure is the main component influencing the ejection fraction, how much blood gets pumped out each beat. Vascular resistance from those precapillary sphincters and blood viscosity also contribute. Normally, if afterload increases, a healthy heart can compensate by increasing its preload to maintain stroke volume. But in shock, with diminished preload from volume loss, this crucial compensation is severely impeded.
The tank is low, so it can't compensate for increased resistance.
Exactly. The body's stress response catecholamines sympathetic activity tries to counteract this by increasing contractility and heart rate, but it's fighting an uphill battle if preload is low.
And down at the tiniest level, the microcirculation.
Microcirculation. The arterioles, capillaries, venules, they play an absolutely integral role in regulating cellular perfusion and are profoundly affected by shock. These tiny vessels are heavily influenced by the sympathetic nervous system. Following hemorrhage, larger arterioles typically vasoconstrict, but in sepsis or neurogenic shock, they paradoxically vasodilate.
Different shocks, different microvascular responses.
Yes. And beyond nerves, vasoactive proteins, vasopressin, angiotensin II, and ethylene-1 cause vasoconstriction, shunting blood away from skin, muscle, kidneys, GI tract to preserve the myocardium and CNS. A critical phenomenon in shock is heterogeneous capillary flow. Even with seemingly okay blood pressure, flow in capillary beds can be uneven. Some areas are poorly perfused.
Why does that happen?
It's likely multifactorial. Endothelial cell swelling, dysfunction, activation leading to recruitment of leukocytes and platelets. These mechanisms diminish capillary perfusion, and disturbingly, this might persist even after resuscitation of systemic hemodynamics.
So even if the big numbers look better, the cells might still be starving.
Precisely. In hemorrhagic shock, usually if we fix hemodynamics and O2 delivery, tissue O2 consumption recovers. But in sepsis, regional tissue dysoxia, inadequate oxygenation often persists despite restoring those global parameters. There's an ongoing debate. Is this due to heterogeneous microcirculation causing shunting within the organ, or is it impaired mitochondrial function? The cells just can't use the oxygen. Some data even suggests limiting O2 consumption in sepsis might be an adaptive response by the cells.
Fascinating. And what about leaky capillaries?
Another huge issue is the failure of endothelial integrity. This leads to capillary leak fluid seeping out and intracellular swelling, resulting in a widespread extracellular fluid deficit. G. Tom Shire did seminal work on this in the 60s, describing third spacing volume moving into areas like the peritoneum, bowel, burns, or crush injuries. Intracellular swelling is complex, but a key part is the failure of energy-dependent pumps, like the sodium-potassium pump when ATP runs low. The cell membrane loses integrity.
And inflammation makes this worse.
Yes, capillary dysfunction is exacerbated by endothelial activation from inflammatory mediators in septic or traumatic shock. This intensifies swelling, leakiness, and increases leukocyte adherence. This interaction can result in the no reflow phenomena. Capillaries stay blocked even after resuscitation, causing more ischemic injury and releasing more inflammatory cytokines, compounding the damage. Experimental models show if you deplete neutrophils in animals before hemorrhagic shock, they have less no reflow and lower mortality. It highlights that double-edged sword of the immune response.
So the big picture is clearly about oxygen delivery and maintaining blood flow, but what happens inside the cells when that oxygen is limited? This sounds like a true energy crisis at the most fundamental level.
It absolutely is an energy crisis playing out right down at the cellular and molecular level. The primary energy currency for nearly all cellular processes is adenosine triphosphate, or ATP. Normally, most ATP is generated through aerobic metabolism in the mitochondria oxidative phosphorylation, and this process critically depends on a continuous supply of oxygen as the final electron acceptor.
Oxygen is key for efficient energy production.
Absolutely. When oxygen tension inside a cell drops, oxidative phosphorylation slows down and ATP generation just plummets. When oxygen delivery is so severely impaired that oxidative phosphorylation simply cannot be sustained, we call that state dysoxia.
Dysoxia. Okay.
In this situation, cells are forced to switch gears to anaerobic metabolism, specifically glycolysis to make ATP. This means breaking down stored glycogen into pyruvate. Now, glycolysis is fast, but it's incredibly inefficient. You only get 2 moles of ATP per mole of glucose compared to 38 moles from complete aerobic oxidation.
Big difference.
Huge. And furthermore, under these hypoxic conditions, pyruvate gets converted into lactate. This leads to a buildup of lactic acid and critically intracellular metabolic acidosis. This drop in pH is a massive problem for the cell.
Why is the acidosis so bad?
Well, the consequences are far-reaching. ATP depletion affects everything that needs energy. maintaining the cell membrane's electrical charge, making proteins and enzymes, cell signaling, even DNA repair. And the decreased intercellular pH profoundly influences vital functions, enzyme activity, ion exchange across membranes, metabolic signaling. These changes lead to alterations in gene expression within the cell. The acidosis also disrupts calcium metabolism and signaling, which are essential for countless cellular functions. All compounded, these changes can rapidly lead to irreversible cell injury and ultimately cell death.
And this leads to the concept of oxygen debt.
Exactly. This state of cellular hypoperfusion leads to what Crawwold termed oxygen debt back in 1961. It's precisely what it sounds like, the deficit in tissue oxygenation over time that accumulates during shock. When O2 delivery is limited, O2 consumption can't meet the metabolic needs, creating this deficit at the cellular level. It can be quantified as the difference between estimated demand and actual consumption. Normally, once perfusion is restored, cells can repay this debt during reperfusion. The size of the debt correlates directly with the severity and duration of the hypoperfusion.
And we measure this indirectly.
Yes, direct measurement is tough clinically, so we use surrogate markers like base deficit and lactate levels, which we'll definitely discuss more when we talk about resuscitation endpoints. Beyond ATP and lactate, that hormonal response we discussed earlier further impacts metabolism. Okay. Catecholamines, cortisol, glucagon, ADH, they induce a pervasive catabolic state.
Breaking things down for energy.
Right. Increased breakdown of stored energy. Liver releases glucose, muscle glycogen breaks down, fat gets broken down via lipolysis. Epinephrine boosts glucagon and suppresses insulin. The net result is hyperglycemia and insulin resistance. This ensures glucose is primarily preserved for the most glucose-dependent organs, heart and brain, even at the expense of other tissues forced into anaerobic metabolism. This protein breakdown also leads to a negative nitrogen balance.
So the body's defense system, the immune system, should help, right? But in shock, it can sometimes make things worse, creating that double-edged sword effect you mentioned. Tell us about these complex immune and inflammatory responses. How do they contribute?
That's an excellent way to put it, a double-edged sword. The immune and inflammatory responses are incredibly complex. It's a delicate interplay of circulating soluble factors and various cell types. They arise in response to all sorts of insults: trauma, infection, ischemia, toxins, even autoimmune stimuli. This system is essentially a built-in surveillance and response mechanism. It's designed to escalate in a coordinated way after injury, to heal tissue or restore the host microbalance. But crucially, it also needs active suppression to return to baseline. The problem in shock is when this system fails to adequately control its activation, escalation, or suppression.
It goes haywire.
Essentially, yes. When that happens, it can lead to systemic inflammatory response syndrome, SIRVAR-ERS, and ultimately potentiate multiple organ dysfunction syndrome, MODS. Both the innate and adaptive parts of our immune system work together. But alterations in the innate immune system activity are particularly responsible for developing septic shock and traumatic shock, and also for the bad consequences seen after hypoperfusion. When mediators meant to act locally gain access to this systemic circulation, they induce widespread metabolic changes, the host inflammatory response. Despite our still limited understanding of how treatments truly impact this response, it's clear that inappropriate or excessive inflammation is central to developing ARDS, MOLIS, and that post-traumatic immunosuppression that makes patients vulnerable.
How does this inflammation get kicked off?
Several ways. Bioactive peptides from neurons responding to pain play a role. But more recently, we've really come to understand the critical role of intercellular molecules released from broken cells. Things like heat shock proteins, mitochondrial products, heparin sulfate, HMGB1, RNA.
The DAMPs again?
Exactly. This is the danger signaling hypothesis Matzinger proposed. These endogenous molecules, the damage-associated molecular patterns, DAMPs, signal danger to surrounding tissues. And they're recognized by those pattern recognition receptors, PRRs, like toll-like receptors, TLRs, and RAGE, the same receptors that recognize microbial PAMPs like LPS.
Right, same alarm system.
Same alarm system. The beneficial side is initiating repair and antimicrobial defenses. However, in excessive tissue damage, the inflammation itself can cause further damage, amplifying the response locally and systemically. PRR activation triggers intracellular signaling, leading to release of cellular products, notably cytokines.
What's the very first cellular response?
The initial response involves tissue-based macrophages and mast cells, acting as sentinels. They quickly release histamines, eicosanoids, tryptases, and an early wave of cytokines. These signals amplify the response, activate neurons and other mast cells, increase adhesion molecule expression on the endothelium, making the vessel lining sticky, and cause leukocytes to release platelet activating factor, enhancing stickiness further. The coagulation and Keenan cascades are also intimately involved, impacting endothelium-leukocyte interactions.
Let's talk about the specific mediators, the cytokines and chemokines. This seems like a complex soup of signals.
It is. The immune response involves a complex interplay of mediators with both pro-inflammatory and anti-inflammatory properties. Our understanding keeps expanding, but it's clear the innate response can either help restore balance or, if excessive, promote dysfunction. Pro-inflammatory cytokines. Key examples. TNF-alpha, one of the earliest, most potent. Released by monocytes, macrophages, T cells, peaks within 90 mins back to baseline at 4 hours, induced by bacteria endotoxin, hemorrhage, ischemia, correlates with animal mortality, though maybe less so in human trauma versus sepsis, effects, peripheral vasodilation, triggers other cytokines, procoagulant activity, metabolic changes, muscle breakdown.
A major player early on.
Absolutely. IL-1 has similar actions, very short half-life, mostly acts locally. Systemically, fever, anorexia, boosts ACTH glucocorticoids, beta endorphins, stimulates other cytokines like IL-2, IL-4, IL-6, IL-8. IL-2, from activated T cells, has a more ambiguous role. Some link it to injury, others link depressed production to immunosuppression post-hemorrhage. IL-6 is consistently elevated in hemorrhagic shock, major surgery, trauma. Levels correlate with mortality. Contributes to lung, liver, gut injury, ARDS. Mediates the liver's acute phase response, complements CRP, fibrinogen, promotes neutrophil activation.
So those ramp things up. What about calming things down?
Anti-inflammatory cytokines. Key example is IL-10. It's immunosuppressive. Increased after shock trauma associated with depressed immune function and infection susceptibility. Secreted by T cells, monocytes, macrophages. It inhibits pro-inflammatory cytokine secretion, reduces oxygen radical production, decreases adhesion molecule expression, suppresses lymphocyte activation, giving IL-10 improved survival immune function in animal models.
A balancing act. And chemokines.
Chemokines are specific cytokines that guide leukocytes' chemotaxis. They influence almost every facet of immunity: development, surveillance, priming, effector responses regulation, directing the traffic, essentially.
Okay. What about the complement system?
The complement system is another powerful cascade activated by injury, shock, severe infection. Contributes to host defense, but also pro-inflammatory activation. Significant consumption after hemorrhagic shock. Activation proportional to injury magnitude and trauma sepsis correlates with mortality, ARDS, MODS development. Activated factors, C3A, C4A, C5A, cause vascular permeability, smooth muscle contraction, histamine or arachidonic acid release, promote neutrophil adherence.
And the neutrophils themselves, they seem central but also problematic.
Neutrophils, PMNs, are indeed early and central, first responders. They perform vital phagocytosis, eating infectious agents, foreign stuff, dead tissue.
A cleanup crew.
Right. However, activated PMNs are also a major source of cell injury and organ dysfunction. They generate reactive oxygen species, lipid peroxidation products, release proteolytic enzymes, elastase, stepsin G, vasoactive mediators. This oxidative burst causes damage. Ischemia-reperfusion notably activates PMNs, causing organ injury. Animal models show neutrophil activation correlates with shock irreversibility mortality. Depleting them prevents sequelae in hemorrhagic septic shock models. Human data also points to their role in MODS. Plasma markers like elastase correlate with injury severity.
So they help, but they also cause collateral damage. What about their interaction with blood vessel walls?
Endothelial cell leukocyte interactions are critical. The endothelium isn't just a lining. It regulates blood flow, leukocyte adherence, coagulation. It expresses extracellular ligands, ICAMs, VCAMs, selectins, which act like Velcro for leukocytes. This allows PMNs to adhere and migrate into tissues to fight infection.
What?
But this same interaction can also lead to PMN-mediated cytotoxicity and widespread microvascular and tissue injury. That stickiness becomes a problem.
And all of this is controlled by cell signaling.
At the deepest level, yes. Shock induces complex cellular changes involving numerous intracellular and intracellular pathways. Mediators interact with cell surface receptors, altering target cell metabolism. These pathways are influenced by cellular oxygenation, redox state, ATP levels, gene expression, intracellular electrolytes. For example, intracellular calcium, Ca2+, homeostasis, is profoundly altered. Calcium regulates so much, and its dysregulation leads to direct injury, activation of transcription factors, changes in gene expression, and modulation of how cells respond to other signals.
So calcium goes haywire. What else?
Kinases like protein tyrosine kinases, MAK kinases, PKC are early steps in intracellular signaling. Their activity is influenced by oxygen radicals and the cell's redox state. These oxygen radicals also regulate key transcription factors like NFKB, apetalol-1, HIF-1, which control gene expression. So oxidant damage isn't just direct injury, it's messing with the cell's control panel.
Altering the genetic instructions.
In a way, yes. Gene expression studies, pioneered by Bookman, show shock causes a global reprioritization of cellular functions, affecting over 80% of pathways in severe stress like trauma or endotoxin exposure. The similarities across different injuries suggest a fundamental human response, often involving dysregulated immunity. Crucially, complications like infections or organ failure in trauma patients seem linked not to a second hit, but to the magnitude and duration of this initial genomic reprioritization. The first insult sets the stage for a prolonged, rewired cellular state.
Wow, that's an incredible journey through the body's internal battle right down to the genes. Now that we understand the universal mechanisms, let's dive into the specifics, starting with the most common type we see in surgery and trauma, hypovolemic, specifically hemorrhagic shock.
Indeed. Hemorrhagic shock from acute blood loss triggers immediate reflexive responses aimed at preserving vital organ function, loss of volume, decreased baroreceptor stimulation, decreased inhibition of brainstem vasoconstrictor centers, increased activity. Simultaneously, increased chemoreceptor stimulation, diminished atrial stretch receptor output. All this results in widespread vasoconstriction and increased peripheral arterial resistance.
The body clamps down.
Exactly. Hypovolemia also strongly induces sympathetic stimulation. Rapid release of epinephrine norepinephrine, activation of renin-angiotensin, increased vasopressin release. Peripheral vasoconstriction is prominent, but brain and heart maintain flow due to less sympathetic effect there and strong local autoregulation. That selective shunting is critical.
Okay, so how do we diagnose this? What are the signs and what are the pitfalls?
Diagnosis. The initial approach is often empiric. Priority 1. Secure the airway in obtunded patients. Then, immediately start volume infusion while simultaneously searching for the cause of the hypotension. In a trauma or post-op patient, you must presume shock is hemorrhage until proven otherwise. Classic clinical signs: agitation, cool, clammy skin, tachycardia, weak absent pulses. Hypotension typically only appear after 25-30% blood volume loss.
So by the time you see the classic signs, they're already significantly down.
Exactly. They're already physiologically decompensated. I remember a case: a healthy athlete came in after a seemingly minor fall. Vitals looked okay, but something just felt off. His lactate was sky high. Turns out he had a significant internal hemorrhage that his body was masking perfectly.
Wow.
That's why those labs are so critical. Younger, healthy patients with their vigorous compensation can tolerate larger losses with fewer signs, maintaining near normal BP until, boom, cardiovascular collapse.
Making early recognition tricky.
Very tricky. Elderly patients are different. Maybe on blood thinners, maybe beta blockers masking tachycardia. Comorbidities like atherosclerosis, stiff hearts limit their ability to compensate. They tolerate loss poorly. Recent trauma data suggests an SBP 110 millimole Hg is clinically relevant hypotension, correlating with increased mortality below that. And vital signs can be misleading. One study, 95% of major hemorrhage patients had HR80, but only 59% had HR120. 99% had BP120, but only 93% had SBP100. Tachycardia is not consistently reliable, present in only 65% of hypotensive patients in one study.
So vital signs alone are not enough.
Well-
What else do we rely on heavily?
This is where serum lactate and base deficit become incredibly valuable. Indirect markers of tissue hypoperfusion, cellular oxygen debt, shock severity. Both initial and serial lactate levels reliably predict morbidity and mortality after trauma. Similarly, base deficit from an arterial blood gas estimates tissue acidosis, stratified into mild, -3 to -5, moderate, -6 to -9, severe, -10 millimole. It clearly correlates with transfusion needs, MOF, and death.
Do lactate and base deficit track together?
Interestingly, while both correlate with shock extent and outcome, they don't always correlate firmly with each other, suggesting both are useful pieces of the puzzle. Regarding hematocrit, admission HCT is associated with fluid transfusion needs, a stronger predictor of transfusion than vitals or acidosis. However, a lack of initial drop doesn't rule out major bleeding. Hemodilution takes time.
So finding the source of bleeding is key. How do we do that quickly?
Identifying sources guides management. Penetrating wounds? Source is usually obvious, needs surgery. Blunt trauma, complex, but large losses usually come from limited sites: external, chest, abdomen, retroperitoneum, pelvic fractures, long bone fractures, non-trauma, often GI tract, external loss, usually obvious, direct pressure tourniquet for limbs, internal loss. Chest cavity, you can hold 2-3L, needs chest tube. Pelvic fractures, retroperitoneal bleed, check pelvic x-ray. Intraperitoneal bleed, most common cause, physical exam is insensitive. Use fast ultrasound or DPL. CT scan for stable patients after initial resuscitation.
Okay, diagnosis is underway. What about treatment? What are the absolute priorities?
Treatment. The cornerstone is concurrent control of ongoing hemorrhage and resuscitation. Patients failing initial resuscitation attempts must be assumed to have active large vessel hemorrhage and need prompt operative intervention. Delay kills. One study. 1% increased death for every 3 minutes delay in the ED for abdominal bleeding.
Time is critical.
Absolutely. Priorities. 1. Control the source. 2. 1A volume, blood products mainly. 3. Secure the airway. Rapid treatment is essential. Sometimes immediate diagnostic laparotomy is needed. You can't truly resuscitate an actively bleeding patient until the bleeding is stopped. This led to the strategy of damage control resuscitation, DCR, from ED to OR to ICU.
And part of DCR is hypotensive resuscitation. Tell us about that.
Yes, hypertensive resuscitation. Initial resuscitation is limited, aiming for SBP around 80-90 millimeter HTR. The rationale, observed by Cannon and WWY, is to prevent blowing off newly formed clots by raising pressure too high too soon.
Let the body clot first.
Essentially, lab studies confirmed, restoring normal BP with uncontrolled hemorrhage increases bleeding and mortality. Bickel's clinical studies showed delayed fluid resuscitation in penetrating torso injury improved mortality. So for penetrating injury, SBP 80-90 millimole HG might be the goal. For blunt trauma, especially with head injury where hypotension is devastating, maybe SBP 110 millimole HG. The key conclusion: both inadequate and unrestrained volume are harmful. Avoid profound hemodilution from excessive crystalloid. Use blood products early.
How do we categorize patient responses?
Patient responses guide next steps. Respond, then deteriorate. Usually ongoing bleeding SOR now. Respond. Hemorrhage controlled, stopped. Shock was limited. Failed to respond. Despite control, ongoing fluid needs, persistent hypotension needing pressors, uncorrectable hyperthermias with coagulopathy. They've tipped into decompensated irreversible shock, widespread vasodilation resistance to pressors, mortality almost inevitable, often diagnosed in retrospect.
A grim picture for non-responders. What about the fluids themselves? Crystalloids versus colloids, blood.
Regarding fluid resuscitation, crystalloids remain the mainstay. Studies show increased death risk with colloids versus crystalloids and bleeding trauma. For severe hemorrhage, volume must be restored with blood products. Hypertonic saline is being studied, potential immune benefits, less reperfusion injury, less brain swelling. Appealing for combat, maybe.
And the transfusion strategy itself. How much blood and what kind?
Transfusion strategy is critical. Stable ICU target is HP 7 to 9 GDL, but no specific trauma trials. Current standard for severely injured is damage control resuscitation. Transfused packed red cells, RBCs, fresh frozen plasma, FFP, and platelets in an equal ratio, 1.1.1.
Equal parts. Why?
Because coagulopathy of trauma develops early and predicts mortality. Military data, confirmed civilianly, shows a high plasma. RBC ratio, like 1.1.4, improves survival and massive transfusion. Low platelets also increase mortality. Increased platelet use improves outcomes, especially in brain injury. Goal 50 by 109L. Whole blood is also regaining interest.
What about specific clotting factors or drugs?
The role of coagulation factor products like fibrinogen concentrates or prothrombin complex concentrates is evolving, maybe guided by levels or TAG. Critically, antifibrinolytics, specifically tranexamic acid, TXA, it inhibits clot breakdown. The CRH2 trial was landmark. Early use, within 3 hours, reduces rebleeding and mortality and trauma, but later treatment actually worsened outcomes. Timing is crucial.
Early TXA is key.
Yes, we now recognize an acute coagulopathy of trauma happens immediately, not just from dilution. Abnormal clotting on admission predicts high mortality. Traditional tests like INR-PTT might not capture it well. Viscoelastic testing, KEG, is increasingly used quicker, more comprehensive for coagulopathy fibrinolysis, better predicts bleeding transfusion needs.
Anything else crucial in managing hemorrhagic shock?
Absolutely. Additional adjuncts. Minimize heat loss, maintain normothermia. Hypothermia is part of the lethal triad. Acidosis, coagulopathy directly impairs clotting, independent risk factor for death. Keep them warm. Paradoxically, controlled hypothermia is being studied for severe shock, the suspended animation idea to limit metabolic demand. Still experimental.
So, traumatic shock isn't just about blood loss. It's this magnified response where the injury itself adds fuel to the fire. What specifically makes it different from pure hemorrhagic shock, like a GI bleed?
That's a critical distinction. While hemorrhage is almost always involved in severe trauma, the systemic response after trauma, combining soft tissue injury, fractures, and blood loss, is a distinctly different physiologic insult. A key difference. Multiple organ failure, MOF, including ARDS, develops relatively often in blunt trauma, but is rarely seen after pure hemorrhagic shock.
Why the difference?
Because the hypoperfusion deficit in traumatic shock is magnified by profound pro-inflammatory activation. Even seemingly simple hemorrhage can induce inflammation leading to cellular changes usually blamed on sepsis. At the cellular level is due to release of those DAMPs, uric acid, HMGB1, RNA activating PRRs, particularly the toll-like receptors, same receptors as bacterial products.
The injury itself triggers a sepsis-like immune alarm.
Exactly. And lab models show this lethality. Adding soft tissue bone injury to hemorrhage kills animals with significantly less blood loss than hemorrhage alone. It's synergistic and destructive. So treatment focuses on correcting all elements to dampen that inflammatory storm. Prompt hemorrhage control, adequate volume resuscitation, correct O2 dead, debride dead tissue, stabilize fractures, treat soft tissue injuries appropriately. It's a holistic approach.
From trauma to infection, septic shock seems like a whole different beast, characterized by vasodilation. How does this final common pathway unfold, and why is it so deadly?
You're right, it's a very different animal. In most shock types, like hemorrhage or heart failure, the body responds to low pressure with profound vasoconstriction. But in vasodilatory shock, most prominently sepsis, this is not the response. Hypotension results from the failure of vascular smooth muscle to constrict properly. It's characterized by widespread peripheral vasodilation, low BP, and resistance to vasoconstrictor drugs. Catecholamine levels might be high, but the vessels just don't respond.
Why don't they respond?
It's due to profound dysfunction of the endothelium and vasculature, triggered by circulating inflammatory mediator cells, or as a response to prolonged severe hypoperfusion from any cause. Interestingly, vasodilatory shock can be the final common pathway for profound prolonged shock of any type: hypoxic lactic acidosis, CO poisoning, decompensated hemorrhagic shock, terminal cardiogenic shock, even after heart surgery.
So it can be the end stage for many types of shock.
It can be. Epidemiologically, septic shock is a huge problem. High mortality, 30–50%, 750,000 U.S. cases a year, a third fatal. Accounts for almost 10% of U.S. deaths, as many as heart attacks. The cause is fundamentally the body's response to a disruption of host microbe equilibrium in invasive or severe infection. The immune system elaborates mediators to kill pathogens, increase procoagulant activity, wall off invaders, increase local blood flow. But if this response becomes overly exuberant or systemic, sepsis manifestations appear: enhanced cardiac output, peripheral vasodilation, fever, high white count, hyperglycemia, tachycardia.
The response goes overboard.
Exactly. In septic shock specifically, the profound vasodilation is largely due to upregulation of inducible nitric oxide synthase, INO, OS2, in vessel walls. INOS produces large, sustained amounts of nitric oxide, NO, a potent vasodilator. This flood of NO suppresses vascular tone and makes the vessels resistant to vasoconstrictors. Endothelial activation injury also contribute.
How is sepsis and septic shock diagnosed now? The definitions have changed, right?
Yes, diagnosis uses standardized terminology from sepsis 3, sepsis, infection plus systemic inflammation, fever, high white count, tachycardia. Severe sepsis, sepsis plus hypoperfusion or organ dysfunction, septic shock. Severe sepsis plus persistent hypotension despite adequate fluid resuscitation, needing vasopressors to keep MAP 65 millimole Hg, often with maldistribution of blood flow shunting. The SOFA score, sequential organ failures assessment, is now widely used to track organ dysfunction and guide management. Recognition often starts before bacterial confirmation. Signs like confusion, malaise, low urine output, hypotension, plus fever, tachycardia, dyspnea should trigger an aggressive search for the infection source: physical exam, wounds, catheters, cultures, imaging.
Treatment must be rapid. What are the key steps?
Treatment starts with immediate assessment of airway ventilation. Obtunded patients, or those working hard to breathe, often need intubation. Given the vasodilation, fluid resuscitation with balanced salt solutions is absolutely essential. The Surviving Sepsis campaign emphasizes care within the first hour. Measure lactate. Start fluids immediately. At least 30 ml L-pterogates crystalloid within the first 3 hours for hypotensive patients. Guide further fluids by frequent hemodynamic reassessment, including lactate clearance. Avoid starch-based colloids. Recent evidence suggests harm in sepsis.
And antibiotics.
Antibiotics are critical.
Yeah.
Get blood cultures before starting, if possible, but initiate broad-spectrum empiric antibiotics within 1 hour of diagnosis, based on likely local pathogens. Tailor narrow, once culture data is back. Minimize long-term empiric use to reduce resistance and complications like C. diff. Source control is vital. IV antibiotics aren't enough for abscesses, infected foreign bodies, dead tissue. Needs drainage or surgery, maybe multiple times.
What if fluids aren't enough to raise blood pressure?
It's still hypotensive after fluids. Vasopressors are needed to maintain MAP, or 65 millimolar G. Norepinephrine is first line, then epinephrine. Argent vasopressin is often effective for catecholamine resistance. Most septic patients have high cardiac output, low resistance. But some have low output despite fluid suppressors. For them, inotropic support with dobutamine is recommended if they show signs of cardiac dysfunction, high filling pressures, low output, and persistent hypoperfusion after BP restoration. Mortality remains high in this group, though.
What about historical approaches like early goal-directed therapy? Is that still the standard?
Looking at historical trials, early goal-directed therapy, EGDT, from Dr. Rivers was revolutionary. Aggressively optimizing O2 delivery early showed huge benefit, emphasizing treatment of that insidious subclinical decompensation.
Right, catching it early.
But interestingly, more recent large trials, Process Promise, didn't show that same advantage for rigid protocol-based care over individualized bedside care. This suggests overall early sepsis recognition and protocolized care, thanks to efforts like Surviving Sepsis Campaign, has improved significantly, maybe leveling the playing field.
Other key management aspects: glucose, lungs, steroids.
Yes. Glucose management. Critically ill septic patients often get hyperglycemic. Intensive insulin therapy, target 80 to 110 milli-GDL, showed significant outcome improvement, reduced mortality, sepsis, antibiotic duration, need for ventilation during renal replacement, ARDS management, common in sepsis. Lower tidal volumes, 6 milli-KS predicted body weight, reduced mortality versus traditional 12 milli-KS TP. Higher PEEP, recruitment maneuvers, prone positioning also show benefit. Prone positioning reduces mortality. Corticosteroids, controversial for decades. Renewed interest due to adrenal insufficient glucocorticoid resistance in sepsis. Some studies showed low-dose hydrocortisone, fludrocortisone lowered death risk in patients with relative adrenal insufficiency, but the large Corticus study found no general mortality benefit. Court guideline. Consider hydrocortisone 200 milligram for 7 days if SBP remains 90 despite fluid suppressors. Finally, numerous adjunctive immune modulation strategies, anti-endotoxin, cytokine antibodies, NS inhibitors, etc., have mostly failed in humans despite animal efficacy. Highlights the complexity of human immune response and challenges in translating lab findings.
When the heart itself fails as a pump, it's a truly desperate situation. How do we define and manage cardiogenic shock, and what makes it so incredibly deadly?
Cardiogenic shock is indeed one of the most dire forms. Clinically, it's circulatory pump failure leading to diminished forward flow and tissue hypoxia, occurring with adequate intravascular volume.
Adequate fluid, but the pump is broken.
Exactly. Hemodynamic criteria usually include sustained hypotension, SBP 90 for over 30 months, reduced cardiac index, 2.2 laminim-2, and elevated pulmonary artery wedge pressure, 15 mmHg, Hg, indicating backup into the lungs. Mortality is tragically high, 50-80%.
What causes it most often?
Most common cause, acute extensive myocardial infarction, MI. It complicates 5-10% of acute MIs, most common cause of death in hospitalized MI patients. Often develops within 24 hours, average 7 hours. Other causes: smaller MI with existing LV dysfunction, severe myocardial contusion, blunt valve injury, direct heart damage, arrhythmias, end-stage cardiomyopathy, myocarditis, obstructions like severe aortic stenosis or mitral stenosis.
And the pathophysiology, that vicious cycle.
The pathophysiology, the vicious cycle. It's insidious. Myocardial ischemia, myocardial dysfunction, more myocardial ischemia. When enough LV wall becomes necrotic or ischemic, 40% fatal cases, stroke volume drops. Distant ischemia can contribute. Most have multivessel disease. Diastolic function also suffers. Decreased compliance, compensatory but detrimental increases in filling pressures. Diminished output triggers reflexive sympathetic discharge. This increases heart rate, contraction, and crucially, myocardial oxygen consumption.
Which the sick heart can't handle.
Exactly. This increased demand often cannot be met by increased coronary flow due to fixed stenosis. So coronary flow decreases, worsening ischemia, acute heart failure, pulmonary fluid backup, further decreasing myocardial O2 delivery by impairing gas exchange. It spirals downward.
Diagnosis must be rapid then.
Diagnosis, absolutely. Rapid ID of pump failure and corrective action are paramount. First, exclude other causes. Hemorrhage, sepsis, PE, aortic dissection, signs. Hypotension, cool mottled skin, depressed mental status, tachycardia, diminished pulses, cardiac exam, dysrhythmia, heave, muffled tones. Confirmation needs ECG and urgent echocardiography. Other tests, chest x-ray, ABGs, electrolytes, CBC, cardiac enzymes. Invasive cardiac monitoring, PA catheter, isn't usually necessary initially, but can help exclude RV infarct, hypovolemia, mechanical complications. In blunt trauma, exclude hemorrhagic shock first. Few blunt cardiac injury patients get pump dysfunction, usually early.
Treatment priorities.
Treatment. Airway ventilation first, often needed to decrease work of breathing gallows sedation. Exclude hypovolemia, establish cardiac dysfunction, support circulation, maintain adequate oxygenation, myocardial O2 delivery, judicious fluids, avoid overload pulmonary edema, correct electrolytes, K, Mg, treat pain, morphine fentanyl, treat dysrhythmias, drugs, pacing, cardioversion. Early cardiology consult is essential, especially with acute MI.
What about drugs to help the heart pump, inotropes?
If profound dysfunction, inotropic support may be needed. Dobutamine, merely beta-1 stimulation, increases output. May vasodilate peripherally, beta-2, lowering BP. Need adequate preload before starting. Dopamine, mixed effects, vasoconstriction, cardiac stimulation, vasodilation. May be better if hypotensive. Caution, tachycardia increased resistance can worsen ischemia. Epinephrine, alpha-beta stimulation increases contractility, HR, but intense peripheral vasoconstriction can impair cardiac performance. Careful titration needed to maximize coronary perfusion, minimize O2 demand. Serial assessment of tissue perfusion vital. Invasive monitoring usually necessary. Phosphodiesterase inhibitors, amrinone, milrinone for resistant shock. Long half-lives risk thrombocytopenia hypotension. Reserved for unresponsive patients.
Any mechanical support options?
Mechanical circulatory support with an intra-aortic balloon pump, IABP, is often required if refractory to drugs. IABP increases cardiac output, improves coronary flow by reducing systolic afterload and boosting diastolic perfusion pressure. Crucially, without increasing myocardial O2 demand. Can be inserted bedside, widely used.
What about protecting the heart muscle itself?
Myocardial preservation is paramount. Adequate oxygenation, judicious volume, minimizing sympathetic discharge, pain relief, correcting electrolytes are fundamental. Anticoagulation aspirin for acute MI. Pharmacologic tools, beta blockers control HRO2 consumption. Nitrates, coronary vasodilation. ACE inhibitors, reduce vasoconstriction workload. Revascularization is pivotal. AHA guidelines recommend coronary angiography for cardiogenic shock, ST elevation LBBH 75. Early definition of coronary anatomy and revascularization is critical. Angioplastic restant preferred if feasible. CABG for multi-vessel left main disease.
Obstructive shock means something is physically blocking the blood flow, essentially jamming the system. What are the main culprits here, especially in trauma patients, and how do we rapidly identify and fix these mechanical problems?
That's precisely it. Obstructive shock is a mechanical obstruction of venous return, depressed cardiac output. Remember, not primary heart failure, but a physical block. Causes: pericardial tamponade, pulmonary embolus, tension pneumothorax, IVC obstruction, DVT, pregnancy, tumor, increased intrathoracic pressure. PEEP, tumor.
And in trauma.
Most common, acutely life-threatening cause in trauma is tension pneumothorax. Air enters pleural space, can't escape. Rising pressure compresses lung, shifts mediastinum, obstructs venous return. Another critical cause, especially penetrating trauma, is cardiac tamponade. Fluid, usually blood, in pericardial sac obstructs ventricular filling. In acute trauma, even small volumes cause tamponade as pericardium can't stretch fast. Chronic conditions, uremia, heart failure, might allow up to 2L. Pericardial pressure is key. Physiology: reduced right heart filling from increased intrapleural pressure and tension PX, or increased intrapercardial pressure and tamponade. Decreased cardiac output plus increased central venous pressure.
Okay, tension pneumothorax first. Diagnosis and treatment. Sounds urgent.
Diagnosis and treatment. Tension pneumothorax. The clinical diagnosis. Don't wait for imaging. Classic findings: respiratory distress, awake patient, hypotension, diminished absent breath sounds on one side, hyperresonance to percussion, JVD, tracheal deviation. Late, empiric treatment, immediate pleural decompression, large needle if chest tube delayed, immediate air rush, rapid BP improvement. Practically, need 3 findings, usually distress hypotension, decreased lung sounds, hypertympany. JVD might be absent if hypovolemic. Tracheal deviation, often late, not obvious. Chest x-ray if done. Mediastinal shift, diaphragm depression, absent lung markings, definitive treatment. Immediate tube thoracostomy, large bore, 4th ICS, anterior axillary line.
And cardiac tamponade, how do we spot that?
Diagnosis and treatment, cardiac tamponade. Causes: penetrating trauma, most common acute source, chronic conditions. Blunt cardiac rupture, rare, can cause it. Manifestations: catastrophic collapse, arrest, or subtle. High suspicion needed. Emergency pericardial decompression, usually left thoracotomy, for circulatory arrest. Other signs: dyspnea, orthopnea, cough, edema, chest pain, tachycardia, muffled heart tones, JVD, elevated CVP, Beck's triad, hypotension, muffled tones, neck vein distension. Classic, but absence doesn't exclude it. Muffled tones hard to hear, JVD masked by bleeding.
What if the patient is stable enough for tests?
Diagnostic maneuvers if stable. Invasive monitoring: elevated CVP, pulsus paradoxus, systolic drop with inspiration, elevated RARV pressure, lacks specificity, time consuming.
chest x-ray, water bottle heart, chronic, but acute effusion often looks normal. Echocardiography, preferred test. Sensitive for fluid, but depends on skill, patient factors. TEE, also sensitive. Shows fluid, RA collapse, poor RV distensibility. Doesn't exclude cardiac injury itself, though. Pericardiocentesis. Diagnoses blood, may relieve tamponade. Safer with ultrasound. May not get clotted blood, risks cardiac injury. Diagnostic pericardial window. Most direct. Done in OR, subxiphoid transdiaphragmatic. Allows direct view. Hemodynamics improve dramatically once relieved. Allows exploration repair via sternotomy or thoracotomy.
This form of shock, neurogenic shock, is truly unique because it's about a loss of control from the nervous system. The brain effectively loses its ability to regulate blood flow. How does that manifest, and what are the critical implications?
You're absolutely right. Neurogenic shock is distinct. It stems from a profound disruption of nervous system control over vasculature, defined as diminished tissue perfusion from loss of vasomotor tone to peripheral arteries. Vessels lose constriction signals, increased capacitance, floppy vessels hold more blood, decreased venous return, decreased cardiac output.
What causes this loss of control?
Usually spinal cord injuries from vertebral fractures, cervical high thoracic, disrupting sympathetic regulation. Rarely SCI without fracture, epidural hematoma. Critically sympathetic input to the heart, rate contractility, and adrenal medulla, catecholamines, may also be disrupted. This is why you don't see the typical reflex tachycardia seen in hypovolemia. The heart doesn't get the speed-up signal, a crucial missing alarm response.
And the injury itself causes more problems.
Yes, acute SCI triggers secondary injury mechanisms. Vascular compromise to the cord, loss of autoregulation, vasospasm, thrombosis, loss of cell membrane integrity, impaired energy metabolism, neurotransmitter accumulation, free radical release. Importantly, the accompanying hypotension worsens acute SCI by further reducing cord blood flow. Management focusing on BP control, oxygenation, optimizing hemodynamics to perfuse the ischemic cord improves neurologic outcome. These patients need ICU monitoring.
How does it present clinically?
Diagnosis, clinical presentation. Bradycardia, slow heart rate, hypotension, dysrhythmias, reduced cardiac output, decreased peripheral vascular resistance. Severity of SCI correlates with CV dysfunction. Complete motor injuries, 5x more likely to need pressors. Classic description. Decreased BP plus bradycardia, no reflex tachycardia. Warm extremities, loss of vasoconstriction, motor-sensory deficits, vertebral fracture on X-ray. Challenges: multisystem trauma, head injury masks, deficits, associated hypovolemia. Note: in penetrating SCI, blood loss is often the cause of hypotension. 74% classic neurogenic, and multiply injured patients always exclude other causes. Hemorrhage, tension, pneumocardiogenic first.
Treatment. Sounds like volume might not be the main issue here.
Treatment: airway ventilation first. Fluid resuscitation is the initial step. Restoring intravascular volume often improves perfusion alone and resolves hypotension in many patients. Vasoconstrictors, dopamine first, then pure alpha agonists like phenylephrine, are only considered after hypovolemia is excluded and neurogenic shock is established. Need for specific hypotension treatment is often brief, 24-48 hours, but life-threatening dysrhythmic hypotension can persist up to 14 days post-SCI. Duration of pressor support may correlate with overall prognosis neurologic improvement. Priority: restore normal BP and adequate tissue perfusion before attempting operative fracture stabilization. Optimize cord perfusion first.
We've covered the different types of shock and how incredibly complex they are, from the initial insult to the body's desperate attempts to compensate. But how do we know when we've done enough? When is the patient truly out of shock, and what does that finish line actually look like?
This is perhaps one of the most challenging aspects, really getting to that master level. The core goal of resuscitation is simple to state but complex to confirm. Restore adequate organ perfusion and tissue oxygenation. Essentially, resuscitation is complete when the oxygen debt is repaid, tissue acidosis is corrected, and aerobic metabolism is fully restored at the cellular level. But clinical confirmation of this remains a significant challenge.
So how do we approach it?
Resuscitation always requires simultaneous evaluation and treatment because the cause isn't always immediately clear. Hemorrhagic, septic, traumatic are most common in surgical patients. For bleeding patients, optimizing outcomes means early hemorrhage control and adequate volume resuscitation, RBCs, crystalloids. Expedient operative resuscitation is mandatory to limit mediator activation and microcirculatory changes that lead to irreversible shock. Attempts to stabilize an actively bleeding patient anywhere but the OR are generally inappropriate. Any delay increases mortality. That's the crucial concept of OR resuscitation.
What about that tricky compensated phase when things look okay but aren't?
Exactly. The challenge of compensated shock.
This is when inadequate tissue perfusion persists despite normalization of blood pressure and heart rate. Studies show 80–85% of trauma patients, even with normal vitals, BP, HR, urine output, still have inadequate tissue perfusion shown by increased lactate or decreased mixed venous O2 set.
That's a huge percentage.
It is. And this persistent occult hypoperfusion is frequent in the ICU and leads to significantly higher infection rates and mortality in major trauma. For example, patients failing to reverse lactic acidosis within 12 hours, despite normal vitals, got infections 3x as often. Mortality was 4x higher. The conclusion is stark. Recognizing subclinical hypoperfusion requires information beyond vital signs and urinary output.
So if vital signs and urine output aren't enough, what are the advanced markers and measurements we rely on to genuinely assess resuscitation success? How do we definitively know we've paid off that oxygen debt?
That's the million-dollar question, and where we turn to more granular physiological and metabolic parameters. Endpoints can be broadly divided into systemic global, tissue-specific, and cellular. Global endpoints, vitals, cardiac output, pathophysiology, O2 delivery consumption, and critically, lactate and base deficit, tissue-specific, gastric tonometry, tissue PHO2 CO2 levels, near-infrared spectroscopy, cellular membrane potential, ATP levels, more experimental clinically.
Okay, let's focus on the key clinical endpoints. Oxygen debt first.
Oxygen debt. Inability to repay it strongly predicts mortality, organ failure. Probability of death correlates directly with calculated debt in hemorrhagic shock. Direct measurement is difficult. Traditional parameters, BP, HR, urine output, are poor indicators of tissue perfusion adequacy, so we rely on surrogates. Serum lactate and base deficit have consistently shown correlation.
Tell us more about lactate.
Lactate mechanism. Generated when pyruvate converts to lactate due to insufficient O2 anaerobic metabolism. Released into circulation, metabolized mainly by liver, 50%, and kidneys, 30%. Significance. Indirect measure of O2 debt approximates magnitude duration of shock severity. Admission level, highest level, and time to normalize lactate are important prognostic indicators. Example, 100% survival if normalized 24 hours, 78% of 24-48 years, only 14% of 48 hours. Caution. Individual variability might be too great for accurate prediction in single cases. Base deficit transfusion volume might be better predictors of mortality than lactate alone in some studies.
And base deficit, how does that compare?
Base deficit, BD. Mechanism, amount of base needed to titrate 1 L whole blood to pH 7.4 standardized. Measured quickly by arterial blood gas, very practical. Significance, mortality of trauma patients strongly stratified by admission BD. BD 15 millimole had 70% mortality in one large study, often stratified. Mild 3 to 5, moderate 6-14, severe 15. Higher mortality with worsening BD. Both magnitude of deficit, BD, and time to correct it are major outcome factors. Clinically, persistent high BD in trauma often means ongoing bleeding. Patients with BD 15 needed 2x fluid, 6x blood transfusion in the first 24 hours. Increased transfusion, LOS, organ failure, mortality correlate with worsening BD. ARDS also correlates with admission lowest BD. Factors compromising utility, bicar admin, hypothermia, hypocapnia, heparin, ethanol, ketoacidosis can affect it. Still, widely used for clinical relevance, accuracy, availability.
What about newer technologies like near-infrared spectroscopy?
Near-infrared NIR spectroscopy. Method. Continuous non-invasive measure of tissue oxygenation and redox state of cytochrome A3, key mitochondrial component. AMITS reflects NIR light. Significance. Max exercise reduces cytochrome A, AKE3 correlating with lactate. NIR compares tissue oxyhemoglobin O2 supply to cytochrome A, AAO3 mitochondrial O2 use. Shows flow-independent mitochondrial oxidative dysfunction, indicating need for more resuscitation even if flow seems okay. Trauma patients with decoupled oxyhemoglobin and cytochrome A3 O2 delivered but not used have redox dysfunction and much higher organ failure rates, 89% says 13%.
Fascinating. Measuring actual cell use. What else?
Tissue pH, oxygen, and carbon dioxide concentration. Method. Direct tissue probes, optical sensors, measure in subcutaneous sites, muscle, bladder, transcutaneous, percutaneous. Promise. Whole promise is continuous monitors of tissue perfusion, giving real-time cellular insight. Right ventricular and diastolic volume index, RVE-DVI. Significance. Seems to more accurately predict preload for cardiac index than pulmonary artery wedge pressure. Ball baby. Increasing RVE-DVI shown to reverse splanchnic ischemia and trauma correlates with preload-related increases in cardiac output. Left ventricular power output, LVP. Significance. More recent endpoint, LVP 320 mHg Lmin M2 associated with improved base deficit clearance and lower rate of organ dysfunction after injury. So these advanced parameters give a much richer, more nuanced picture of resuscitation adequacy than just vitals, helping us know when that oxygen debt is truly repaid.
Wow, we've truly gone on a deep dive into shock from its historical roots, with trailblazers like Bernard and Cannon, to Blaylock's critical insights, and then through that intricate dance of neuroendocrine and immune responses that characterize the body's battle. We've explored the cellular energy crisis, the double-edged sword of inflammation, and all the way to modern, data-driven resuscitation strategies for hypovolemic, traumatic, septic, cardiogenic, obstructive, and neurogenic shock. Understanding these layers, from global hemodynamics right down to cellular and even genomic changes, is absolutely essential for true mastery. As you reflect on all this, what stands out to you? Perhaps it's the idea that a subtle change in the body's oxygen debt could be a silent predictor of danger, even when everything else seems normal on the surface. Or maybe it's that revelation that your own body's danger signals, those DAMPs and PRRs, trigger the same fundamental alarm bells as a bacterial infection, amplifying the response in such profound ways. How might our growing understanding of these intricate cellular mechanisms lead to entirely new ways of diagnosing and intervening in shock, perhaps even long before it reaches that terrifying irreversible phase?
If we connect this to the bigger picture, it's clear that the more we understand these fundamental physiological responses at every single level, the better equipped we are to not just treat, but truly anticipate and potentially prevent the devastating consequences of shock. This knowledge isn't just for medical professionals. It's really a profound window into the incredible resilience and also the profound vulnerability of the human body. We hope this deep dive leaves you not overwhelmed, but intensely curious to explore even further.
Absolutely. Thank you for joining us on this vital journey. Until next time, keep digging deeper and stay curious.